Hi, Lindsay.
Hi, Abby. How are you?
I'm well. How are you?
Doing great. Thank you.
I'm so happy to
Excited
see
to be
you.
here.
Yeah, me too. So many things to talk about. Why don't we start with what is a metabolic health practitioner?
Yeah, great way to start. My name's Dr. Lindsay Ogle. I'm a board certified family medicine and obesity medicine physician. My path to really focusing on metabolic health started with really just wanting and prioritizing a goal of achieving health and well-being for my patients. And so that led me to pursue family medicine and primary care, and then ultimately led me to obesity medicine and that field and helping patients to treat really the underlying cause of so many of our chronic conditions. And a lot of that has to do with excess weight and our lifestyle. Really, with that additional education, learning how interconnected a lot of these common conditions are, like type 2 diabetes, PCOS, fatty liver disease, metabolic syndrome, high blood pressure, all of those sorts of conditions are really a large part related to our metabolism. And so that has been my area of focus most recently in my clinical practice.
Wow. Okay. And can we define what obesity is? And then maybe talk about what we think it should be or shouldn't be?
Yes. So that is really up for debate right now. A lot of medical societies are tweaking their definition of obesity. And so I think commonly what most people think of is the BMI, which is really should only be used as a screening tool. So the BMI takes into account somebody's weight and their height, but it does not take into account their age or gender or body composition or their overall health. And so it's leaving out a lot of really important factors. But we can use it as a screening tool because it is easy to do, easy and inexpensive to do and monitor over time. But if we are using BMI as a definition for obesity, then a BMI of 30 or greater classifies as obesity. But there are other ways that we can classify it, and that can be looking into body composition.
Hold on, I want to pause
But
you for 1 second. I just want to
yeah,
explain for anybody that might not know that BMI is body mass index. And what it's measuring, you're talking about body composition, but at the onset, what is it actually measuring before we get into dissecting it?
yes, it measures somebody's height uh, in relation to their weight.
So they're getting a number basically saying, if you're this height, this is what your weight should be. And if it's above that, your BMI gets a different rating. And that's your, like you're saying, your sort of red flag or marker to see if something else is going on.
Correct,
Okay,
correct. Yeah. Mhm.
perfect. Okay.
Absolutely. Yeah, yeah. So calculating your BMI will give us a number, and then that number will fall into a category or range, and one of those ranges is obesity.
Okay. And are there different ranges? So you said age is not always considered. So I assume there's different ranges for children, teenagers, women versus men. Why do we make some like women versus men? Why do we make some of those assumptions that those numbers should be different?
So that's one of the flaws in the BMI is that there is no distinction for
Oh,
men or
wow.
women currently. Yes, yes. For children, there is a distinction, and that's based off of the growth chart. And it's a little bit more complicated because we're taking into account what we would expect somebody's height and weight to be for their age and their trajectory on that growth chart. So it factors in percentages that way. But if we are just looking at adults and we tend to classify anyone 18 or older as an adult, it does not take into account somebody's gender, which is a major flaw of the BMI system.
And then it doesn't take into account like muscle mass, right? That's what you're talking about in terms of body composition.
Correct, correct. It's
Whoa.
not, or age.
Okay. So let's say you get somebody with what, a 31 BMI, so they're over the 30 threshold. What do you start looking for to see what else might be going on? And can you tell physically when you look at somebody? Obviously, I don't mean in a judgmental way, like from a
Mhm.
physician's perspective. Can you be like, oh, I think I know what might be going on, or I think I see there's some underlying issues here?
Yeah, I think that's actually a great question. And what we can potentially visualize would be abdominal obesity. And that's really what we are looking for, that extra weight in the stomach area is what is more likely to attribute to metabolic conditions or other health conditions. And so that can be something we could potentially quickly visualize, but there is a way that we can measure somebody's waist circumference. And that is another metric that we can collect or watch over time that can give us more information about whether or not someone has obesity and whether or not that BMI category that they're falling in. So if they do have a BMI of 31, if they have a larger waist circumference, then it is more likely that their weight is affecting their health versus somebody who has a smaller waist circumference and they have a BMI of 31, then their weight is less likely to impact their health.
What do we strive for? I guess it's hard to answer this universally. I can say selfishly, I'd love to know, like, as a female in my 20s, 30s, 40s, what do I want my ratio to be in terms of muscle mass in my body? Is that
Oh,
like an
muscle.
easy number to find, to figure out?
Yeah, it is hard because it varies from person to person. And if you are looking at um, particularly muscle mass, so there's different ways to or fat mass, did you say?
I said muscle mass, but I'm open
Yeah.
to discussing either
Okay.
one.
Yes, yes. So that can be a very helpful, marker of information to have. Ways to go about actually collecting that can be as scientific as getting a DEXA scan, but that can be more expensive to do. And depending on your area, it may be available or not. And then there are um, home scales that you can purchase that can estimate your body composition and how much fat and how much muscle that you have. And so what I tend to do with my patients, if we were watching those numbers over time, would really be to get, that baseline. And then every so often, based on what our treatment plan is and goal is to watch those numbers. And so, especially if we are working on weight loss, we want to make sure that we are, doing everything we can to maintain that muscle mass and focus on fat loss versus, losing muscle mass along with that weight loss. So it's not an exact answer because, like you said, it does vary from person to person. But it can be helpful to watch. And with many things in medicine, we're looking at the trend over time because there is such a continuum of what is considered healthy or optimal or what could be negatively impacting our health.
So, given all these numbers we're talking about, what are the ones you think are important for us as an everyday person to track?
Mhm. Yeah. So weight is still a great thing to track. If you are at a point emotionally where you can, get on a scale and look at it as a neutral number and watch it over time. I recommend that my patients either weigh themselves once a week or if they weigh themselves every day to really kind of get an average of what their weight is that week and watch that average over time. Because especially for women, but for anybody, our weight fluctuates fairly often based on what we've ate or how much sleep we got the night before. or if we're sick, or women in our cycles, there are changes constantly happening. And so we're really looking at that average over time. So weight is still really helpful for us to monitor. Another thing that is great is just how we fit in our clothes. Are our clothes feeling tighter? Are our clothes, fitting well? Are they looser? That's a great indicator, and can be kind of a proxy for that waist circumference without actually having to measure that. So that's a great thing to watch over time. And then if you do go so far to buy one of those body composition scales, that is something that you could monitor. Most physicians in obesity medicine recommend only checking that about once a month. Because there are those fluctuations on a day to day that can really um, confuse the picture.
Yeah.
And so again, watching the trends over time, like taking a step back and looking at the bigger picture.
Why is it that gut, your stomach, your waist circumference is the alarming area? Why is that?
Mhm. Great question. And what that is a proxy for is um, what we call oh gosh, I'm totally blanking on the name. Well, what we're really worried about is extra fatty tissue in and around our organs. And when that occurs, then that is what can lead to chronic medical conditions. The most common example of this is fatty liver disease. And this is a fairly common condition that often gets overlooked, but is a precursor to other conditions like type 2 diabetes. So that's one example. So in our abdomen, we have a lot of our organs in that area. And so if there is extra, you know, fatty deposits in those areas, then that is where we see um, an enlargement in that area. And also insulin resistance. So is something that we always need to think about. When somebody has insulin resistance, then they are more likely to put on the extra weight in the abdominal area versus like in the arms or thighs or butt or hips. It's more likely to go into that abdominal area.
We've talked about this on my pod before, and I still find it fascinating and never fully understand. Can we get into what insulin resistance is and how it manifests?
Yeah, so we are learning more and more about this all of the time. So it used to be thought of as mostly genetic, and there definitely is a genetic component where somebody is more, predisposed to developing insulin resistance. And from that standpoint, it's really looking more at like that lock and key theory to where insulin is the key that goes to a lock on the cell that helps bring in the sugar in our body so it can feed the cell and the cell can do whatever it's needing to do. But if there is a error in that messaging or that lock and key signal, then the insulin can't work and blood sugar levels rise, and that's what over time leads to prediabetes and diabetes. Um, while that insulin is not working, then our body is gets the signal we need more insulin to overcome that dysfunction. And so insulin levels rise along with the rise in the blood sugar. And insulin is a storage hormone. So normally in, our in healthy bodies or in all of our bodies, when we eat something, insulin is released because it is helping us to process the calories and the sugar that we ingested. And so when our insulin levels are high, it's a way of telling our body we have extra energy. Let's store it for a later time. And so if someone has that insulin resistance going on in their system, they're constantly having higher levels of insulin and they're in storage mode. And part of that is telling your body, let's store that energy, and it gets stored in our fat cells, and it's trying to, help us in those times when later on maybe we did not have um, access to additional energy, additional food. So then we can use those stores later on.
Mm. Okay. So I feel like insulin resistance gets more complicated as we age. Is that
Mhm.
true?
Yes, it becomes much more likely to develop as we get older. That's definitely true.
Okay. So what are some of the things we can do to keep that in check?
Yeah, absolutely. So, as I mentioned earlier, that insulin is released in response to eating food. So, one thing that we can do is to have breaks and periods where we're not eating. And, commonly this is known as fasting, but we all do some amount of fasting. So, while we're sleeping, we're not eating. And that is a time when our body can have, naturally lower insulin levels. And so some people really do respond well to either time restricted eating or intermittent fasting. Other people don't do so well on that. So that's definitely an individual approach. But even if you are somebody who is eating, the standard 3 meals a day, which I do tend to recommend, um, cutting out snacking in between meals can be a powerful way to have some of those reductions in your insulin levels. Also, avoiding added sugars as much as possible, especially sugar sweetened beverages. Those will really spike your insulin levels. Um, Another tip I really like, because this is not restricting anything at all, is just simply to focus on protein and fiber in your meal first. If you eat those first, then you are um, going to be able to stabilize your insulin and your blood sugar later on. And it also helps you feel full and then get in the nutrients that your body is really craving and
Okay.
desiring.
So that's great. So why is it if you have your protein and your fiber first, is that like then the insulin is busy doing other things and can't start storing the sugar for you? Is that a
Um,
crazy question?
no, it's not a crazy
I mean,
question.
I know it's a
Um,
fairly common knowledge. Eat a lot of protein and eat it first in your meal, but why?
mhm, mhm. Um, the reason it's not that the insulin is busy managing that. It's that you do not need as much of a release of insulin initially. And so it's more of a steady and lower release of that insulin. So you're not having that,
The
big
spike.
spike.
Got it. Okay.
And that's where we see a lot more of the metabolic disturbance, the ups and downs in our mood and our energy levels when we have those spikes. And so it's really about keeping that a little bit more stable.
And then just to speak to one other thing you said, I feel like there's always the eat snacks more often, keep your metabolism going. But what I heard you
Mm.
say is that giving the break and not snacking as much kind of is a mini intermittent fast and gives your insulin level a chance to balance out. Why do we hear both of these? And you might have, like, obviously, your opinion is to do the intermittent piece of it. Why would someone else maybe be a proponent of the other way?
Yeah, absolutely. So everybody is different, and I strongly recommend an individualized approach to any, lifestyle recommendation or medical recommendation. So I definitely think that there is room for both for the right person. Um, and for sure, if somebody has had a history of bariatric surgery or maybe on a medication like a GLP-1 where they're not able to eat as much or not recommended to eat as much in one meal, they may need to eat more often throughout the day to get the nutrients that they need, that their body needs to function appropriately. There are also other people who are just grazers, and that's how they were made, and they do better that way. And that is fine as well. If you find that you work better as kind of that grazer um, type, phenotype, then just yeah,
Me.
then definitely with those snacks, then focusing on protein, fiber forward snacks, and you get a similar result. I think the issue is if you're hungry between meals, or you're busy and you only have a quick break at work, then it's very easy to reach for those snacks that our brain may be telling us that it wants in the moment, that has a lot more sugar in it, and that's what we want to avoid. And so, if you do snack, that's totally fine, of course, but then focusing on the fiber and protein during those snacks.
Okay. And you brought up one thing, and then I really do want to get into sort of a fertility lens through this, but
Hmm.
GLP-1s,
Hmm.
why are they so popular? Who are they for? Can you get me some? Just kidding. Um, but I would love to understand how they work and why they are so popular right now.
Yeah, absolutely.
I live in
So,
LA. Don't forget, I live in LA. It's like basically sold on every street corner.
oh my gosh, absolutely. So they've really been around. The first FDA approved GLP-1 was in 2005. I believe that was Byetta that was approved at that time. So they've been around for 20 years. And they started off as medications for type 2 diabetes, but of course, we now know that they are very effective for weight management. So they help in many different ways. And the three main ones that the three ways that I describe it to my patients who are using them for weight management, is one, they block hunger signals and those hunger hormones to the brain. So people just either they don't feel like they're hungry as often, they don't think about food. That's when people are talking about the food noise being suppressed or taken away altogether. I often have patients say that they're not craving those foods that they were previously craving, and now it's just so much easier to stick to that diet that they've been trying to follow for so long. The other way that it works is it slows down the gut motility, and so you feel full sooner and for a longer period of time. And that is really where we see the common side effects of nausea, upset stomach, constipation, heartburn, because of that slowing of the gut. Um, and there are some things that we can do to work with those side effects, but those are the common side effects. And then the effects on insulin and blood sugar. And so it helps to keep those levels much more stable, as we were talking about earlier, more of the, nutrition way to go about it. These medications just augment that. And so they help regulate the insulin levels to allow your body to release those excess fat stores that it had developed previously.
If that were the benefit for everyone, why wouldn't everyone take one?
Hmm. Yeah, that's a great question. So with anything in medicine, we are always thinking about the risks and the benefits. And so with any treatment, there are some risks that are involved. And with these medications, the GI side effects that I mentioned, um, there also is concern for possible, the thyroid cancer concerns. Those have yet to be fully proven in human studies, but are there. Um, and then, oh, totally blanking.
Like
And then,
why
of
why
course, the
everybody
cost.
wouldn't take it. Yeah. Why
Yeah,
everybody
yeah.
yeah.
Of course, the costs, especially right now, are very high. But so when any doctor is evaluating a patient, and they're deciding should we use this treatment or not, yeah, we're thinking of those risks and those benefits. And so somebody who is in a quote unquote healthy weight, or they do not have any weight-related conditions, then it is not worth the cost and those potential side effects to use this medication. But if somebody has been struggling with excess weight and obesity for years and decades, and they have not been able to, achieve their goals without this treatment, then it is worth for most people trying a medication like a GLP-1 agonist under the guidance of their doctor.
Okay. So you didn't prove me wrong that like I shouldn't go to the street corner and buy it because my gut is not exactly where I want it and my cholesterol is a little high. Damn. Okay.
Yeah.
So let's talk about this in relations to pregnancy and fertility. Um, so complex. Let's talk about it in terms of PCOS, but
Mhm.
also I want to get into BMI because BMI is often a deal breaker for people to get fertility treatment. And I think I've seen it really heartbreak so many people. So let's just talk about why. Let's start with PCOS. I know I like lay it all out there, but I just want to grab my train of thought. Why, like, what is the correlation between obesity, weight in general, and PCOS?
hmm Yes, and I'm so excited to talk about all of those things.
Okay.
And so, yes, PCOS, very, very common in women of reproductive age. It depends on, what studies you're looking at, but a good estimate is about 10% of women have PCOS. And the majority of women who have PCOS have overweight or obesity, but not everybody. But that is a risk factor. PCOS is one of those conditions that are multifactorial in how they develop. So there's definitely a genetic predisposition. It's more common if you've had other family members have PCOS. There's environmental factors. There's the weight component. And then there are factors that we are still discovering all the time. And this really gets back to the insulin resistance that we were talking about earlier. So PCOS, insulin resistance, excess weight, they really intertwine here. And insulin resistance is a component of PCOS. And when somebody is having, like we talked about earlier, they have insulin resistance, their insulin levels are higher. And insulin has an effect on the ovaries in that it tells the ovaries to release more of the androgen or typically considered the male type hormones, and that interferes with ovulation. And so women with PCOS are more likely to have irregular cycles or to not ovulate all. And that is what then leads to often, but not always, difficulty with fertility. And that is also why losing some amount of weight, and it for PCOS, it can be as little as 2.5, 5% of your body weight can improve your likelihood of ovulating and becoming pregnant. And this is where some of those guidelines with treatments, I think, are created.
Okay. When you say, so with PCOS, your brain tells your ovaries maybe not to produce as many quote unquote female hormones. So that's why we see symptoms such as like more hair growth. Is testosterone raised? Like, what are some of the other symptoms that would be considered androgen symptoms?
Yeah. So if you had your blood if you had your hormones checked in your blood, oftentimes women with PCOS have higher levels of testosterone or other androgen hormones, but not always. That is not always present. Sometimes it's just the ratio in those androgen levels compared to the female hormones. And so that's one way that we can look at it, but we also can look at what symptoms you're having. And getting back to your question. So what we would see would be more acne along the chin line or those darker, thicker hairs along the chin line. Sometimes hair loss, especially like on the sides of the head or in the back of the head. can be some common signs of that androgen excess.
Interesting. Okay. So I want to talk about BMI and fertility. A lot of times there is an arbitrary, it can feel arbitrary. I'm sure there's some reason behind it, but there's an arbitrary number at which a fertility doctor will not, let's say, perform IVF on a patient because their BMI is too high. And it can be so heartbreaking for the patient, especially ones who feel like they've been working on their weight and eating so clean and all the things. What is the reason behind that number, and is it arbitrary?
I think it is. And to be honest, I never knew about this until I had some of my female patients, when I was working in a primary care clinic, come to me and tell me that they were denied fertility treatment because of their BMI. And yeah, they were devastated because they already feel like their body is not working properly, or they did something wrong, and now they're being told that because of their weight, that they can't receive this treatment that they so desperately need and want. And so I was surprised to hear that was certainly the case. And before this talk, I tried to kind of look in to see if there's any particular guidelines, and I didn't find any clear recommendations or guidelines that are consistent throughout different states or treatment centers as far as fertility treatments go for like a BMI or weight cutoff. I think that there's different reasons that some clinics do that. And I think some of them may be legitimate, and then some of it really I think comes from weight bias and misunderstanding. Um, some of the potentially like legitimate reasons would be true concern for these women and their health and their pregnancy outcomes, because we do know that there could be complications with pregnancies at higher BMIs. Although, of course, that does not mean that women with higher BMIs don't deserve to become pregnant. They absolutely do. I just think that that's a thought that these physicians may be having. Um, I also think that they are worried about the success of the treatments. And we know that these treatments are often very expensive, and many women do not have coverage, unfortunately. And so, they're paying out of pocket, and maybe they're thinking about, that cost for these women. Um, but that also ties into, I think, some of the other maybe not so legitimate concerns, because my understanding is a lot of these clinics really advertise their success rates. And so I'm sure that they are looking for, the most quote unquote ideal candidates to undergo their treatment so they can have those higher rates of success. And then, like I mentioned earlier, there's definitely a lot of weight bias out there, and a misunderstanding of how difficult it is to achieve and maintain a healthy weight. And especially when you're going through something as stressful as infertility, and potentially have already undergone treatments previously, that can make it harder to maintain your weight.
Mm. I've also heard for BMI, you have to undergo very quick anesthesia for an egg retrieval, and sometimes there's a concern with BMI and anesthesia. Is that true?
There is. I don't know exactly what that anesthesia looks like for those treatments. And I'm not an anesthesiologist, but I do know that weight is something that is factored into, surgical risk in general.
Okay. Um, so if we're obese, what's the first thing we do to help to get ourselves in control?
Yeah. Um, that's a great question. I I think there's a couple of things to do in parallel. Um, One is, and potentially this is that first one, then is to kind of take a pause, and it sounds so cliche, but taking a deep breath and relaxing. There is nothing emergent or urgent that you need to do right now. I think the healthiest thing to do is to take that pause and make space for love and compassion and acceptance. Um, the second thing that I would do would be to find whether it's a healthcare professional, a doctor, a dietitian, a coach, a community that you can turn to for support and guidance, because this is something that we all need. And I think finding somebody who you trust, whether you already have an established relationship with them or you know somebody who has had a good experience with them or you've read reviews about them online and you know that it is somebody who is not going to judge you or shame you, because unfortunately that does happen quite a bit in lots of spaces and even in the medical community. And so looking for those trusted areas of support, and schedule. And if it is that, a doctor that you trust, scheduling that appointment to talk about a plan for your health moving forward.
So is in terms of the patients you see, is that the part that you do? What is your range of topics you generally cover with your patients?
Yeah, so a lot of different things. Having my training in primary care, I talk about a lot of different things at almost any part of, health and wellness. So everything from preventative health, and making sure my patients are up to date on their screenings because we often overlook that. On the mental health side, screening for eating disorders, which are very, very common. Um, Talking about workup that we need to do to check for metabolic dysfunction. Um, Talking about where we're at currently, and that may be reviewing, a nutrition log or what we're doing for physical activity or how much sleep we're getting. And then with the patient creating, a small adjustment that is reasonable and actionable and working on that. And then once we, have got that on a routine, then going to the next one. So it's a lot of different topics and often takes several visits to, fully, accomplish where we're at. And truly, we're never fully there, right? We are continuing to improve our health and well-being over time.
So do people see you long term?
Yes,
Okay.
yes.
Okay. This has been so fascinating, Lindsay. Thank you so much. I like to close always by asking people if they have a cliche that they like, and I feel like you already gave us take a breath, which I think is such an important one. Is there any other one, maybe from like a family member or a piece of advice you once got that you think about all the time that you can share with us?
Yeah, so one that I really like is you just, by looking at somebody, you never know what they're going through and what stresses and burdens they're carrying with them. And so just always, approaching people with kindness, that goes a long way.
I love that one. Thank you so much for being here. We will link out to all of your info. And if you're in Missouri, you can find her in person. And I hope you do. Thanks for being here.
Thank you for having me.